is Negedu Agada Godwin, and I'm your regular uncle. Today we're going to be looking at liver ultrasound. Before we begin, please like, share, subscribe, put on notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019144175, or you can visit our online store at sonography.business.site. Attempt the quiz at the description and you can leave me a comment. Welcome back. Let's take a look at parenchymal echotexture, considering the echogenicity ladder of normal tissue. Generally, while scanning, we assess the echotexture and echogenicity of one structure by comparing it to another adjacent normal structure. For example, when scanning the right kidney, we assess the right renal parenchyma by comparing it to normal adjacent liver tissue. The normal renal parenchyma should be considerably less echogenic than the normal adjacent liver tissue. If the renal parenchyma is similar in echogenicity and the liver is normal, then we can say the renal parenchyma is normal. The fundamental rules when using this echogenicity ladder are that you compare the tissue that are adjacent and the comparison tissue should be normal. It's also imperative that the TGC control are properly set. Texture is the concentration of parenchymal cells in an organ. Sparsely spaced cells in an organ will be described sonographically as having a coarse texture, for example, the pancreas. Densely spaced cells give rise to fine texture, for example, the renal cortex. The echogenicity ladder of normal tissue in the upper abdomen is seen in an increasing order, like you see in this chart. The renal parenchyma is less echogenic than liver parenchyma. The liver parenchyma is less echogenic than the spleen, and the spleen is less echogenic than pancreas, and the pancreas is less echogenic than the renal sinus. Now, that is from the least echogenicity to the most echogenicity. From the most echogenicity to the least echogenicity is renal sinus, pancreas, spleen, liver parenchyma, and renal parenchyma. Take a look at this image. The normal homogeneous liver has a bright echo texture when you compare it to the renal cortex. And this other image, you note the echogenicity of the pancreas is more than the liver and that of the renal cortex, but less than the renal sinus. In this image, you note the echogenicity of the renal sinus, which is most echogenic than the renal cortex, the liver, and the pancreas. The renal cortex, as demonstrated in the image, has the least amount of echogenicity, less than the liver and the pancreas. While in this image is an image, sonographic image that shows renal failure. Well, in this case, there's a reverse echogenicity that leaves the renal cortex more echogenic than the liver tissue as compared to the adjacent normal liver. Let's look at normal sonographic appearance of the liver. First, let's consider the size. The size of the liver has been measured by many methods, but here, the length is measured at right mid-clavicular line, and 14 centimeters is considered normal on the average. The anterior-posterior diameter in transverse plane at the right mid-clavicular line should be about 8 to 10 centimeters. The AP diameter of the left lobe at the midline is maximum up to 6 centimeters, and the length should be about 8 to 10 centimeter when you measure it in sagittal plane. This we'll discuss further. The shape is normally described as pyramidal. However, it has no clinical significance. The normal liver surface should be smooth in contour with no lumps protruding or indenting it. In other words, there should be no nodularity. The liver, the inferior border of the liver is acute angle edge. Considering the texture and echogenicity, the normal liver has a characteristic parenchyma echotexture, typically slightly more echogenic than the renal parenchyma. The liver parenchyma is homogeneous and of medium texture and echogenicity, and is interrupted by tiny bright and dark foci representing hepatic vessel and ligaments. Within this background, you have the hepatic vein, which are visible as anechoic structure that drains superiorly into the IVC. You have the portal vein. Here you see the lumen is also anechoic, but it has an echogenic wall owing to the surrounding connective tissue in the portal tract. You have the hepatic arterial branches, which are generally not visible without color Doppler. You have the normal bile ducts. They are not visible only when they are dilated, of course. Liver capsule, also known as the Gleason's capsule, appears highly echogenic specular reflector. Commonly, the capsule echoes blend with adjacent structures such as anterior wall muscle or the diaphragm. Now, in this image, you see the normal sonographic appearance of liver. Here, the normal length of the liver is measured at right mid-clavicular line, usually up to 14 centimeter, which is considered normal. This cut at the right mid-clavicular line and also displays the right kidney. On this image, you notice a normal liver echotexture. On sagittal view, it shows normal homogeneous echo pattern of the liver. The liver is more echogenic than the renal cortex. Then this image shows differentiation of the hepatic vein from the portal vein. This image shows the portal triad at the liver hilum. In liver hilum, we see portal vein entering into the liver. Two slim lines above the portal vein are hepatic artery and bile duct. On color Doppler, the blood flow in the hepatic artery can be confirmed. Let's look at the normal variants that is possible. And the very most common is the radial lobe. This is the most commonly recognized variation in liver shape. It is an inferior extension of the right anterior segment of the liver, anterior to the right kidney. It may extend also to the iliac crest. It is more common in women and may present as a right upper quadrant mass. Variation in size and shape of the caudate and left lobe are also common. Small left lobe is common. Complete congenital absence of a lobe or segment is pretty rare. Variation in the venous drainage, we have 30% of subjects have an additional left hepatic vein, 3% have mid hepatic vein, and 80% have the right hepatic vein. These drain into the IVC together with the normal hepatic vein at the cranial end of the liver. An accessory right hepatic vein presents in 60% of people and drains into the IVC directly in a more caudal location. And this image shows the radial lobe and the anterior extensions that is possible. Also, the ultrasound image of the radial lobe, which sometimes is seen in women. Normal measurements of liver, normal liver, diagnostic ultrasound is more accurate than physical examination in assessing the liver size. Pitfalls of physical examination in determining liver size are many, including the subject's body habitus, presence of ascites, chronic obstructive disease, respiratory physicity, and inter-observers variability. Right mid-clavicular line is the most common method for routine assessment of the liver size. The right lobe is about 13 to 15 centimeters in length approximately. It is measured in longitudinal scan in the right mid-clavicular line, parallel to the anterior abdominal wall from the right dome of the diaphragm to the inferior margin of the liver. Now, if the length is greater than 15 centimeters, it is considered hepatomegaly in about 75% of the cases. However, size will increase with height and body surface area and decrease with age, of course. These parameters should be considered in borderline cases. Other additional measurements can also be considered, like AP diameter in right lobe is 8 to 10 centimeters, like we said, in the right mid-clavicular line anterior-posteriorly. The AP diameter of the left lobe does not exceed 6 centimeters when you measure in the midline. Accurate positioning of the probe is important, as the right lobe may measure more than 15 centimeters in length when measured laterally. Other indirect signs of hepatomegaly, it's a large liver beyond the normal size. You have the extension of the right lobe below the lower pole of the right kidney in absence of radial lobe. So this is important if you just want to do a subjective measurement by observation. So if you consider the extension of the right lobe below the lower pole of the kidney, and you are sure that radial lobe is not the case, then you can say that is hepatomegaly. Also, you can look at the kidney, you will see a rounding of the caudal margin of the liver on sagittal view. You can also use that as a subjective method to measure, to consider hepatomegaly. Extension of the left lobe into the left upper quadrant above the spleen is also one of the indirect signs that we are looking at hepatomegaly. Summary. Let's look at a quick summary of the liver anatomy. There is the main liver fissure. This is a true internal cleft or interlobar fissure that corresponds to a line that is drawn from the IVC fossa to the gallbladder fossa. And these fossas are impressions that are made on the liver surface by the IVC and the gallbladder. Mid-hepatic vein, right portal vein, gallbladder, and IVC can be visualized along this line. This fissure divides the liver into right and left lobe. It is important landmark to locate the non-visualized gallbladder. So where the gallbladder is shrunken, or whatever the case that is absent, you can use the mainly lobar fissure to to trace where it's located. Left lobe is divided into lateral and medial segments by the left intersegmental fissure that contains the left hepatic vein, left portal vein, and falciform ligament. The two segments, that's the lateral and the medial, they are divided by the left hepatic vein, left portal vein, and falciform ligament. We form the left intersegmental fissure. The lateral segment is divided into two, the superior and the inferior, when you use the conoid system, by lateral, superior, and inferior branch of the left portal vein. Medial segment is divided into superior and inferior by the medial branch of the left portal vein. For the right lobe, it is divided into anterior and posterior segments by the right intersegmental fissure, that is the right hepatic vein. Two segments you see are anterior and posterior, divided by the right hepatic vein. Anterior segment is again divided by is further divided into two by the right portal vein and or its posterior branches. Posterior segment is divided into superior and inferior by the right portal vein branch. The caudate lobe is completely separate. It's a complete separate lobe supplied by the left and right portal vein and the left and right branch of the hepatic artery. It is bounded posteriorly by the IVC, anteriorly by fissure for ligamentum venosum. That fissure contains the ligament proper, a remnant of the fetal ductus venosum, and is also bound inferiorly by porta hepatis. The fundamental vascular rule here is the hepatic veins are intersegmental, that's between segments. Portal veins are intrasegmental, within segments. Bile ducts and hepatic artery travels with the vein, forming the portal triad. And I hope this fundamental rule will help you to divide the liver so that you know which segment you're seeing a lesion or pathology. Now, portal vein, we have the main portal vein. It divides immediately after entering the porta hepatis into the right portal vein and left portal vein branch. The right portal vein branch, the first part that goes off posteriorly to the medial segment of the left lobe before entering the right lobe. It gives off a branch to the caudate lobe. The left portal vein, the first part is called the horizontal or transverse part. That is a pars transversa that goes around the anterior border of the caudate lobe before entering the left lobe. The second part, you call that the ascending or the umbilical part. It goes anteriorly into the left lobe, dividing it into the medial and the lateral segment. While the ligamentum teres, that's a round ligament attached to the tip of the ascending portion of the left portal vein. Now, the porta hepatis is an area surrounding the entrance of the liver. It is outside the liver. Therefore, any structure located within the porta outside the porta hepatis are outside the liver and said to be extrahepatic. These extrahepatic structures are terminal parts of the main portal vein. The entire length of the left and right portal veins prior to their bifurcation into the segmental branches. The right and left hepatic artery, the right and left ducts, and the beginning of the common hepatic ducts. Part of the non-dilated central intrahepatic biliary tree can also be visualized close to the porta hepatis. However, the caliber of normal intrahepatic biliary tree should be less than 2 mm and less than 40% of the accompanying portal vein. Now, let's see the sonographic anatomy of the liver. In this image, you see the main lobar fissure. Then on the sagittal view, it shows the main lobar where you have those black arrows as linear. The main lobar fissure, it appears as a linear hyperechoic structure between the right portal vein and the gallbladder. The gallbladder is represented as G, the right portal vein as P, that's the main lobar fissure. And on this image, you have main lobar fissure still. On transverse view, it shows the main lobar, you see the white arrows, which appears as a hyperechoic linear structure, and is found in a line that joins the gallbladder with the IVC. And on this image, the main lobar fissure is seen as hyperechoic linear structure, represented as the white arrow still, separating the right lobe and the medial segments of the left lobe. The black arrow shows ligamentum teres, which appear as a hyperechoic structure with slight acoustic shadowing. So when you see that, it's not calcification. It can be mistaken for calcification, but it's not. Then the hepatic vein on transverse shows the three, on this image, the three major hepatic veins: the right hepatic vein, the mid hepatic vein, the left hepatic vein. They are all seen draining into the IVC. The left hepatic vein and mid hepatic vein join together before they drain into the IVC, as you see on the image. So the right hepatic vein separates anterior segments of the right lobe from the posterior segment of the right lobe. The mid hepatic vein separates the anterior segment of the right lobe from the mid segment of the left lobe. The left hepatic vein separates the medial segment of the left lobe from the lateral segment of the left lobe. We have the right hepatic vein on this image. Is a branch of the right hepatic vein is seen, separating the right lobe into anterior and posterior. Transverse view, here you see a branch of the right hepatic vein. Look at the arrow that demarcates the plane of separation between the anterior and posterior segment of the right liver lobe. And more views to see the right hepatic artery that runs just above the right portal vein on this image. Now, like I've said before, you visualize this by turning on your color Doppler. You see color flow. That is a confirmation that that's the right hepatic vein. Then on this image, this is actually the portal vein on transverse view. You see the horizontal portion marked as L, of course anterior to the caudate lobe, which is C. Ascending portion of the left portal vein marked as A, crossing within the left intersegmental fissure that separates the medial LM and the lateral LL segments of the left lobe. Can you see that? On this image, you have the main portal vein, sagittal anatomy. The sagittal view shows the main portal vein, can be represented as P. then the IVC, of course. On this image, you have the main portal vein on sagittal oblique view, demonstrating a long segment of the main portal vein. This is also right portal vein, sagittal view of the right lobe of the liver, demonstrating the right portal vein. On this image, you have right portal vein, anterior and posterior branches. On the image, sagittal view of the right lobe of the liver, more laterally this time, demonstrates anterior and posterior branch of the right portal vein. Here you have the left portal vein ascending portion. On the sagittal view of the left lobe of the liver, you demonstrate the ascending portion of the left portal vein. And S represent acoustic shadowing from the fibrofatty tissue within the ligamentum venosum fissure. Remember I said it's not a classification, but the ligamentum venosum will produce that. The shadowing mimics a hypoechoic mass in the caudate lobe, so you want to maneuver properly to or adjust your keys to actually rule out whether it's a mass or it's not a mass. But on the normal situation, it's not a mass, it's just shadow from the ligamentum venosum fissure. Then this image shows the fissure for ligamentum teres. The open arrow you see is ligamentum teres coursing within the caudal third of the left intersegmental fissure. That solid open arrow you see, they separate the medial segment of the left lobe LM from the lateral segment of the left lobe LL. Ligamentum teres appears as hypoechoic structure with acoustic shadowing. That is the acoustic shadowing for ligamentum teres is represented as S. You can see an hypoechoic area. The falciform ligament, the solid arrow you see on your left, appears as a linear hypoechoic structure anterior to ligamentum teres. There is just close to the GB. G represents the gallbladder. And this image also shows the caudate lobe. Sagittal view shows on the caudate lobe situated between the fissure for ligamentum venosum anteriorly and IVC posteriorly. Fissure for the ligamentum venosum is seen as linear hypoechoic structure that separates the caudate lobe C represents the caudate lobe from the lateral segment of the left lobe LL. Main portal vein P is seen inferior to the caudate lobe. While this image shows the caudate lobe on transverse, situated between the fissure for ligamentum venosum anteriorly and IVC posteriorly. Fissure for ligamentum venosum, represented by the arrow, extends to the margin of the left portal vein, close to the origin of the ascending portion of the left portal vein. R represents the right lobe, S represents shadowing from fibrous tissue around the left portal vein. Now this table, I will leave it for a few minutes, shows the anatomic structure that are useful for dividing and identifying hepatic segments. So I'm sure it's going to help you look at the structure, look at their location and how they are useful. With this description, I hope the question of sonographic anatomy, identifying structures, the normal liver structures, has been dealt with. And remember, in sonography, when you understand the normal, you will take care of the abnormal. So the best way to understand pathology is to know the normal anatomy. So thank you for joining this lecture today. Please like, share, subscribe, and put on notification for all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144 175 or visit our online store at sonoeyes.business.site. Attend the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning this.